so much pain, I went to go to the hospital, and then I developed shingles. So needless to say, I had 2 months of sheer agony,
Yeah. So,
and I've fallen twice in the last 2 weeks.
goodness.
In fact, twice in about 4 days, my right knee is buckling.
Okay,
And,
right knee. So right-sided pain, hip and knee.
now the shingles are gone, but the pain is still there. I feel like I have electrical current running through this right leg.
And a fall history, okay. So, ma'am, if you don't mind maybe sharing some your story, or it's okay if you don't want to, you don't have to.
My name is Chris. I had just some really intense tightness around this knee over the last month,
Okay,
and it's,
got your walking
I
cane there.
got my walking so I can move.
Okay,
And I went and got a cortisone shot, but it hasn't made any difference.
okay,
I noticed when I went home and I did a little bit of stretching exercises, it did make a little bit of a difference, so
Okay, good.
I'm hoping tonight I can learn some more exercises to like really move forward
okay.
with that.
And, sir?
Richard, worked for a phone company for many years, climbed the poles and all.
Yes, sir.
And, I got both my knees are bad.
Okay.
The, bone on bone, I've had Sensvic 1, Sensvic 2, rooster cone shot. What she said, I'm just going as long as I can. I got another schedule with my pain management doctor to get shots in them again next week, so I
Yeah.
went through physical therapy. It just doesn't work for me. I have continuous pain all the time, especially when I'm sitting.
Right.
I mean, I can walk and it starts hurting, but if I'm sitting, it just throbs like a pain that maybe through the foot.
Okay, so baseline pain constantly, and it increases with activity. Ma'am, if you don't mind sharing?
Yeah, my name's Karen,
Okay,
and I have problems in my left knee from a meniscus. I have arthritis problems, but that one doesn't hurt me anymore. It's my right one, and the doctor says I've got arthritis in that as well. I got a cortisone shot, which took away the pain, but I have like zero range of motion. If I have really hard time walking, it feels like I've got like a 5-pound weight wrapped around my leg, and
Yeah.
I can't bend very well. And just,
okay. Yeah, so you have some range of motion restrictions. It's funny, not funny, but it's, interesting how the left side was the problematic side, and now the right side's hurting. So, and there's answers for why that happens, and we see it's a common pattern that we see when people come in with knee pain. So thank y'all for sharing, and so hopefully we can give y'all some answers to some of these questions that y'all are having tonight, and kind of move forward with what y'all are dealing with. So Tiffany's gonna kind of go through some of the worksheet questions that
Yeah,
y'all
if you
have.
grab your worksheet, y'all, we'll go ahead and start with what is the knee? The knee's a hinge joint, kind of like a door opens and closes, right? So it's a hinge joint. We have a pretty little drawing here of what the knee looks like. So movement, what does the knee do? It bends and it straightens, so that's where the hinge comes in, it bends and straightens, right? There's 2 large muscle groups, and I'm probably going too fast, y'all let me know when you're ready. The 2 large muscle groups, you have your quadriceps and your hamstrings. They work together, not only to make the knee work, but those are the large muscle groups that we really focus on for the knee. There's 3 different bones. The thigh bone is called your femur, F-E-M-U-R. The shin bone is your tibia, T-I-B-I-A. And then your kneecap is your patella, P-A-T-E-L-L-A. P-A-T-E-L-L-A.
Like Nutella.
Oh, I like that. I'm gonna tell people that. I like that. Thank you. So yeah, we had one.
Yeah, so we heard a couple people say, Mr. Richard, you said that, bone on bone. That's like something that gets tossed around. Doctors say it, we say it, PT say it. Like, what does that really mean? And is that like a definitive diagnosis, or that kind of like, is it a sentence for surgery to have bone on bone? And the answer is no. Bone on bone, it comes in a spectrum or an umbrella. It's not just, so it could be mild, moderate, severe. And so the knee, the ends of our bones are covered in cartilage. And the cartilage, as it kind of maintains space. If you look on an X-ray, there'll be space on that X-ray between the bones on a healthy knee. As that cartilage wears down, as the cartilage wears down through, hi,
Sorry.
welcome. As the cartilage wears down over time or with faulty mechanics, there's a number of things that can cause it. There's different levels, like I said, mild, moderate, and severe. And so it's not a sentence of surgery because the knee works, it's trapped between the ankle and the hip, right? And so I guess deficits that can occur in the ankle affect the knee. Deficits are things that are happening in the hip, weaknesses in the hip or restrictions in motion that also affects the knee. So just because you have bone on bone doesn't mean that we can't work on other joints above and below and the knee itself to help improve your overall function. So, you know, in the past, this one patient in particular that came in recently, they were a 65-year-old male, had a big family trip coming up and for spring break or whatever. And so his goal was to be able to go on this family vacation without pain. He had a bone diagnosis, was limited range of motion, painful walking, and without surgery, we were able to help them achieve that goal to where he can go on that vacation successfully and, you know, make good family memories. Was his pain, you know, it wasn't perfect, but it was to where at the point he was functional, operational, he did really well. He was really happy with his outcome, as were we. So, so that's kind of a success story that we've had with bone-on-bone diagnosis. So how I came to treat knees and become like a knee specialist, Tiffany and I, is just hands-on treatment, seeing thousands and over the years of knee patients, post-surgical, in other words, before surgery, after surgery, people that are trying to not have surgery at all. And so we've gotten really good at it over the years, not just here in the clinic, we're really good, not to talk ourselves up, but I guess so. But the, just PTs in general. So in the early 2000s, they did these surveys for how satisfied people were with their treatment from PT clinics. And so in the early 2000s, there was about a 25% satisfaction rate. And over time, that's progressed where, like, over the decades, I guess, from 25% to 50%. And currently in the 2020s era, the techniques that we have, the knowledge that we have on mechanics and interventions that work, 90% success rate is kind of a common goal that we have and what the stats are saying. Back to normal, that's where we want to get y'all. So the first steps of doing that, Tiffany's gonna go over some of it.
So just to catch you up, on the second page there's a paper that we're kind of going through and we're answering questions. So you know, because we were looking at here, we're kind of going through, helping you answer them. So if your knee pain is reproducible, so that's the word there, reproducible, then it's reducible. So what does that mean to y'all when y'all hear that? If it's reproducible, it's reducible. If I'm getting up from the chair and it hurts, obviously something is affecting that. So we're able, exactly. So we're able to help you work to reduce and to correct that. There's some sort of musculoskeletal complication there that's causing that. So in the past 30 days, your worst pain you had was 0 to what? Now you said 2, at least, sitting. So right now it's always 2 out of 10, right? Isn't that what you were saying earlier? Mr. Richard, your pain, 0 to 10?
2 to 3.
2 to 3? Yeah.
Just sitting.
So just sitting. So go ahead and jot down what your pain is at rest, and then what is your pain at worst? And then also take a second to look, so when you have pain, circle. Is it walking, stairs, sit to stand, standing for long periods of time, kneeling, bending, running, jogging? Take a little second to jot down what, she's like, running. If someone's chasing you, no, I'm kidding. She's like, let me just circle all of them.
If there's a fire, I'll run.
Yeah.
So, the next thing we wanna talk about is what's the single biggest mistake that you can do? What do y'all think is? Ignore it. Yeah. Pain is there for a reason. It's telling you something's wrong. It's telling you something's going on there. Yes, we use pain and we control it. We need to have pain for a certain reason, but we also don't wanna have too much pain. So there is something to be said for taking care of your pain. So there's 3 different things that could actually affect and cause your knee pain. Sorry, 3 things you can do. Let me correct myself. One is what? Ignore it, right? The first thing you can do is ignore it. What can I do about it? Just ignore it. The second is alter it. So I heard a lot of people say injections. That's the cortisone. That's altering it. Injections, medications, injections in the knee, and medications like topical creams, as well as say when you're sitting and you go to get up and it hurts your knee. So what are you gonna do? You're gonna slightly bend over. You're gonna come up after you're altering your movement. So that's something that you're gonna be doing. And the third thing is handle it. And what we do in PT is we basically figure out what the underlying cause is, and then we help you to correct that, to make those changes to not only decrease your pain, but hopefully get rid of your pain completely. You wanna do the 4 causes of pain?
So yeah, if you continue to look down your sheet, the top 4 causes of knee pain, A is ligament, sprain or tear, so ligament. So it could be a ligamentous type injury. There's several ligaments of the knee, that cross the knee, on the outsides, on the inside, so that's one of the more common ones. The meniscus, probably heard of the meniscus. They're 2 C-shaped discs that sit between the 2 bones. They bring stability and depth to the joint, and they live in this space here. And they absorb shock. And so these are weight-bearing structures that are stressed with weight-bearing and rotation. So think about all the wear and tear through your lives. It's common for these things to be worn down.
With the meniscus there, let's say only one side of the knee, let's say the external, because mine is, it's more touching, and the rest is there's still lateral meniscus, right? That's the term, I think. Where you still have a little bit less than 50%.
Okay.
Yeah.
So how's it bone on bone? Do they just consider it automatic because that little section there is a little bit closer than the rest?
It's like we said, like the bone-on-bone diagnosis. It's not really a diagnosis, but the bone-on-bone, I guess, description that, how it describes what they're seeing on an X-ray. It's on a spectrum of mild, moderate, severe. And so what they're looking at is that the cartilage is worn down. And I see what you're saying. If the meniscus is still intact, it's there. Why does they say bone on bone? Part of what I'll see, because I don't have X-rays, I don't have MRIs, but what we look at is functional movements, and presentation postures. So there's things that we can, just by analyzing somebody's posture, it's a good indication if the medial compartment's worn out, the inside compartment, or the outside compartment can be worn out because it presents with maybe knock-kneed or bow-legged. Right, for somebody that has severe degeneration. Or maybe it's other things that coming from the hip, or males versus females, and so there's indications, and there's things that we can work on to try to, reduce those stresses that we see that are happening on them. But to your point, yeah, some compartments can wear out more than the others, and how they come up with the bone-on-bone description is purely based off of an image. Not of your functional mobility. That has nothing to do with the way you walk or the way where they stand. It's solely off a picture.
So even the picture is just, again, indicating just that little corner side of it. How can it fully be bone on bone?
That's like the blanket term, like the umbrella of the
Just
term.
the umbrella,
Yeah, it's kind of
okay.
like the umbrella he was talking about earlier. It
Okay.
just could be either spectrum, mild, moderate, severe. Yeah.
So we
So
call
it's
you
kind
like,
of, yeah.
like a mild bone on bone on the lateral compartment.
Yeah.
Right. If they really wanted to get down to the nitty gritty,
Yeah.
but typically they'll say, "Hey, you got bone on bone." So okay, so ligament, meniscus, everybody hears the meniscus. And one more thing on the meniscus, they don't heal very well, they have poor blood supply. So anyhow, that's why they're most commonly injured. Top 4 causes of knee pain. C, arthritis. Old uncle arthritis. D would be, ma'am?
Yeah.
Yeah, arthritis. So D, problem in the ankle and foot, hip, and the last blank is low back. So what, that's kind of, I alluded to it earlier. The knee is trapped between the ankle and the hip. What happens when our feet hit the ground, it impacts our knee. So if I have, let's say you have somebody that has a fallen arch or they're flat-footed, their knee's gonna tend to fall further inwards. Or let's say somebody has weakness on the outside of their hip, they're not gonna have as much control of their thigh because the muscles of the hip control the thigh. So that changes the stresses that go through the knee. And over time, it develops into arthritis or meniscus degeneration and so on and so forth. Okay, so the next item of discussion is images, because we talked a lot about images, X-rays, MRIs, and whatnot. And so I guess the stats that are out there are, in my opinion, are hopeful, because you can take, like, what they've done is they've taken people off the street and they asked them, do you have knee pain, yes or no? And then they would do images of them and see if there was, you know, bone on bone degeneration, positive findings on an X-ray or MRI. And so what's interesting is that, so for people over 50, it took 100 people that were over 50 years old, and they had no pain, but many of them, I think 80% of them had signs of bone on bone, degenerative disc, or meniscal tears. There was no imbalance or tightness of the muscles. And so what that means is you can have a positive finding on an MRI or X-ray that you have bone on bone or an injury, but you can have no pain, right? Because it's just a picture. So it's how the overall, how you are working overall your mechanics, right?
So just because you have it does not necessarily mean the pain's gonna be there, essentially.
Right. Do y'all understand that, what I was trying to say there?
Yeah.
So yeah. So, Tiffany, you want to talk about item 7?
So what can we do? What's non-invasive? So that's kind of when I think about PT, I think of what's invasive, what's not invasive. So obviously surgical is more invasive. And some people are just surgical candidates, that's okay. So we see patients all the time prior to surgery, and when I tell you the success rates that I have seen from my patients, say you have a total knee, bone on bone, they're like, you can't do anything, you're bone on bone, you're gonna surgery. Okay, the ones that I have seen post-op who have come to us prior, who have a strong BMO, that's a muscle within your quadriceps, or they have strong and good hamstring control, you're gonna see a difference. You're gonna have that muscle memory post-op whenever they've already cut through everything, moved everything around, put it back. That muscle control and that muscle memory is gonna come back as well. So there is something to be said. Should you be like, well, shoot, I have to have surgery. It's like a lost cause. Not necessarily. There's definitely, obviously, the surgery is gonna be great because it's gonna correct your joint, but you're also gonna have a quicker and a better recovery due to having PT. So what do? We do, you can see the answers right there. It says, so what does successful and non-invasive treatment look like? It's hands-on PT, so that's hands, to move the knee and surrounding joints. Stretching and strengthening exercises to gain, again, that muscle memory. And then there is classic laser. The answer is laser there.
What's it for? A class 4 laser?
Class 4 laser, yeah. Oh, I said classic, sorry. Sorry.
So yeah, the laser is just one of many
Yeah.
modalities that we have that can accelerate healing processes. You know, there's heat, there's stem,
Sound.
there's ultrasound, there's laser.
Manual therapy, which we do to help the tissue function. Any fascial restrictions inside the muscle, it sits within a fascia. It's kind of like when you pull the chicken, the skin off the chicken, you know, it connects, that's your fascia. It helps to get things moving and functioning better. So if you have any restrictions, you might be able to fire that muscle correctly because you have the restrictions. So I was working on those using different tools, not just our hands, but we have actual tools, cupping and Graston tools, which is like a little metal tool to help break that up. So we have so many different,
Dry needling is
dry
another.
needling's another one, yeah. So I didn't think about
The
that.
laser is external,
Yes, sir.
Yes, sir.
Yeah, it's a
just like heat.
It's
it's like heat, it accelerates. Yeah, it's like heat, it accelerates, cellular changes and healing processes. It's just one of many things, many tools in the toolbox to really, that PT can utilize that are non-invasive. Yeah. And yeah, we can get you more information on that.
Absolutely.
It's not an end-all be-all, it's a piece of a comprehensive treatment plan that we would develop for you.
Yeah.
How do you get in there too? Cause I mean, with mine, I don't know about these others, if I could take this kneecap off right here, I could just scrape the pain away and put it on.
Yeah.
And it's not on the side, just right below the kneecap.
Yes, sir. So that's another part of the knee, you know, we didn't get into too much detail of it, because everybody's case is different.
Yeah.
But the knee, you know, we kind of touched on it, that it involves the femur, the tibia, and the patella, right? Patella. So, what you're talking about, you're referring to kind of like the patella femoral joint, where the patella meets the femur. It's different because that one's not so much the hinge that the tibia and the femur interact, but it's the one that's on top that slides and glides. Our patella gives us leverage, and it enables us to stand up out of a chair. It gives us mechanical leverage. So without your patella, your quads really aren't that as strong as we would like to give them credit for. So anyhow, so what you're describing is kind of, that's where your pain is, the patellofemoral joint. So there's things that we can do, hands-on treatments, not necessarily to eradicate your arthritis, but to lengthen the tissues, the fascial plane, and the other structures around it, so it's good and strong and mobile. And everybody has a ceiling that they'll eventually hit. And that's what Tiffany was kind of talking about. Even if ultimately somebody winds up needing to have surgery, we do kind of like, think of it as like prehab, where you're preparing yourself for surgery. The more function and the more strength that you have in your extremities, the faster your recovery is going to be after a surgery. Yes, sir. I mean, it's just, if you're right now, let's just say you're operating on a scale of 0 to 10 and your function is say a 4. If I get you up to a 6 and that's your ceiling as high as I can get you, you go and have surgery and it's gonna knock you back, it's gonna knock you down. It'll knock you down to a 6, or from a 6 to a 4. But if you go in at a 4, it's gonna knock you down to a 2. Does that make sense?
Yeah.
So yeah, so there's things that we can address and try to improve your function, because we're not trying to improve your x-ray. We're trying to improve your functional mobility. Get you to go on that vacation, to go, you know, hiking on the trails with your family, if that's something that whatever your goals are.
So can we have everybody stand up? I want to try something with y'all really quickly. We're just gonna stand up and just do just a little squat down like that, like almost like you're gonna try to sit in your chair. And I want to see who and if anyone has pain, just doing a little down and up. Down and up. Who has pain with that?
I have
Yeah.
pain.
If I go deeper down, I'm gonna.
Right.
Okay.
Right.
So hold on for support. Give yourself some support. Do just a
Do a
little, I
couple
want
more.
you to kind of pretend just like you're sitting in a little chair, little squat. I call it the porta potty hover for the women, you know what I mean? Porta potty hover. We all know how to hover. Good, and come back up. Try to keep those heels down.
Pardon me?
Try to keep those heels down. There you go, good. All right.
You having pain with that when you?
Is that one hurting?
My
Which-
pain is not so much moving.
It's when you're
I'm
sitting still,
And
yeah.
I'm laying, that's when my pain comes in.
Right, it's
And I
after.
could walk
hurting.
a mile down there now.
Where?
That's good. You don't need to do any more squats.
Okay.
Can I see you? Can you have you come up here? I just want to do a little demonstration and see. And your pain is on your
On my leg,
leg.
Here's a little stool.
from my hip on down.
Let's actually, I'll probably get you to sit right here. Can you sit on the edge of the table here? And it's the right leg.
Right.
Okay. So I'm just gonna do a few things. This is just, where are all the spoons? They moved them
And
all.
also, I
They
knelt
took our
down Saturday
They're back there.
outside, and
That's all right.
I couldn't get up.
It's okay.
I will, I definitely will. Let me grab the stool.
I'm listening. What were you saying?
Get up. My knee wasn't getting, couldn't get up.
Okay. And why wouldn't your knee bend? It locked up?
I was down, that's on the way around,
Oh.
and I was down on my knees, and I made sure that, because it doesn't want, like you said, it doesn't want to lift.
Right.
So I always try to make sure that I have something I can hold on to, but
So you try to let it go?
I couldn't unbend it.
Right. It locked up, it was stuck on. What do you You feeling any difference when I'm kind of pulling on your leg here?
Actually feels kinda good.
Or? And how long you been dealing with your knee pain? You said for a long time.
Well, actually, I had a back injury
That's right.
about 6 years ago, and I've been dealing with a lot of time, you know, it just comes and goes. Sometimes you can pick up a 100-pound sack and it's fine, and the other time you can step over a piece of paper and throw it out, so you don't know. But, when I went to therapy and got in that traction, first time I went, I thought, oh man, this is wonderful, it felt so good, I felt loose, and I noticed that my leg is beginning to shift, my weight is shifted, my body shifted. And I've always been very active up until a couple months ago, I did anything I wanted to do. And now, this leg is, but I don't know that, it hurts in the joints,
Mm-hmm.
but the stinging and the burning, I'm sure came from the shingles, and
Yeah.
the trauma from the pain that I was having from that last fraction I got is what they think triggered the shingles.
All right, let's see, can you do your little squat again, how you just did, and see if that kind of changes any of that discomfort that you have in your... So before, is it better, worse, or the same?
I can't really tell, like say this pain, this leg stays this much pain
Yeah,
regardless,
all the
you know,
time.
from the ankle all the way up to the hip bone.
So I'll tell you, like, so one of the reasons why I wanted to kind of just check on her leg real quick was because when she was doing her squat, her heels were coming up instantly. So, and I probably should have had her do a squat so y'all could have seen it beforehand. But now she's able to keep her heel down just from kind of pulling on her knee, and so the function of her squat, the way it looks is improvement slightly.
Good.
But you're, just with just doing that little technique, but your overall pain still stays the same. you
Well,
know, or
like I say,
slightly.
now, it feels like it's swollen, it feels like, almost like it's got fluid on it,
Mm-hmm.
but it's very weak. You know,
Yes,
I
ma'am.
don't trust
You don't trust
leaning
it.
off on my right foot,
Yeah.
especially since I fell on the stairs one
Sure.
time.
And that's what I think it's so important, what Matt just did to you, is that functionality of when you're getting up and down out of a chair, and like you said, when you're moving, having that increased function. He did just a little bit of distraction at your knee and your ankle, gives you a better function. So think about the falls that you've been having, getting up and down, you're walking, the improvements that will make from long term. And it's you know, just again, one of our little tools in our toolbox.
Yeah, it
but-
was just
yeah.
a little distraction, a little bit of stretching her ankle,
Mhm.
enable her to keep her ankle down and do the squat. So,
It's good to exercise it instead of just.
Absolutely.
Yes.
Okay.
move it or lose it.
Move it or
right?
lose it.
And that's what I'm afraid of. That's exactly what I'm afraid of.
But we're so glad y'all came. We really enjoyed talking with y'all. Do y'all have any questions for us regarding anything that we asked? I know we have Sherry here as well. She's gonna come up here and kind of give y'all an idea of if y'all do want to take that step and to kind of trying to get control of that pain, and you wanted just to kind of see, get one of our PTs to look at you and kind of give you a feedback on what they think. We have a couple options for that. But we really appreciate y'all coming out and taking time again for yourself. That's what's really important.
Yeah.
We
You guys-
appreciate y'all being here. and
Thank
giving us the
you.
opportunity.
What do you guys think of that over-the-counter supplements, the glucosamine, chondroitin? Is it your experience that these things work for people, or should they just not waste their money?
I've been taking it for many, many years, so I'm still got knee pain and back pain at home.
So I'm smiling because it's my first day of PT school, like the first day, this was a question that was posed by our professor, you
That's
know.
so funny.
So we had to, that was what we had to do, is look it up and see, and take a stance on it. And so, my stance on that is, there's no harm in taking it. However, it just depends on where you're at in the degenerative process. It's not gonna hurt anything. If it's something that you wanna invest some money in and try, I would say that go for it. However, I wouldn't put all my eggs in that basket. Everybody's looking for a pill to take
Yeah.
that cures all their issues. And ultimately, what it comes down to is, taking control of it and doing something about it. And That's what we do here, is we try to restore normal function to reduce the stress that goes through your knee and decreases your pain and improves your overall quality of life. So I would say to the chondroitin sulfate and glucosamine, if you haven't tried it, yeah, give it a shot. But it's probably not gonna fix your issue long term. Restoring normal mechanics is what's gonna correct your problem.
I have a question related to that. I just ordered and just received a supplement like she's talking about. But this one also talks about having a type of collagen that can
Okay.
help to restore cartilage, to grow cartilage again. Is that possible?
I'm not sure about the supplement you're talking
I
about.
haven't tried it yet. I haven't talked to my doctor about
So,
it.
yeah.
That's a good,
Yeah, definitely, I would talk to your doctor and you probably get
Is
some.
it possible to get cartilage going again?
It's difficult. It's difficult because, like I was talking about the meniscus, and the meniscus is cartilage, and the cartilage that's on the ends of our bones, they don't have the best blood flow. So there's the knee joint in particular, it's a synovial joint. It has a membrane around it, and that has blood supply and nerves that are connected to it. And so through movement, the nutrition, the synovium, right? That's for the nutrition that is provided to the joint, to the bones and the cartilage. It comes through movement and kind of, think of it as like the more you move, the more lubrication you get to the joint. And so the supplement that you're taking is gonna have to go through your digestive system and eventually make its way through osmosis and movement inside the joint where it can then do its thing. So I'm not gonna say no, I don't even know the supplement you're talking about, but I would say that it's not gonna hurt you, most likely not hurt anything to take something like that. And or again, restoring normal mechanics is gonna be the key to controlling pain and managing it long term. It is very difficult to grow cartilage because it doesn't have a good blood supply.
Question, what runs behind the knee here?
So there's
a sharp pain through that area.
There's a lot of things that run back there. So you have your hamstrings, right?
No, this was like the knee.
So your hamstrings cross the knee. They start all the way up at your hip, and there's long muscles that come all the way across the knee. This isn't the best drawing. So anyhow, there's four muscles of the hamstring that cross the knee. Then you also have the capsule that's very deep in there. Then even deeper is you have the meniscus, parts of the meniscus that are back there. You also have all the nerves. Your sciatic nerve, it splits right here, and then part of it runs down the back of your leg. The blood vessels are all back there. And then you have your calf muscle also is back there. So there's a lot that goes on the back of the knee. It's a very loaded question.
Yeah, it's very low.
My knees are I can just move the wrong way.
Yeah.
I call it a flare up.
Sure.
I just stepped in my kitchen, going around my counter, and it was like,
Yeah.
and I had pain running behind my knee.
Sure.
And I didn't know whether that was a ligament or what it was.
Yeah.
And it could be just that general muscle imbalance that we're not having there within to support that joint from the front and the back. So that's where in the evaluation process, they literally dive in and check every single piece, check every box, check everything to really get an individualized program for you.
Yeah.
So that's where it's, like you said, it's kind of a loaded question.
It's very loaded. It depends, but there's a lot that goes on
But so
behind
much,
it.
absolutely.
It is high value real estate behind the knee, for sure.
You
Did you have
guys
a question?
made reference earlier about having maybe pain on one side and it produces pain on the other. Well, I mean, again, I had pre-existing arthritis in both knees, but by far this right knee has been my worst.
Yeah.
And when I had a fall back in September, but much improved now. But it's now producing a pain right here on my left.
Yeah. And sometimes it's just the way you walk in too. You
And
have a
mine
pain, so you
favored
change the
and-
way you walk, and so
yeah.
then you're gonna have that. I think it was you that was saying that you were walking and the other one started acting up as well. It
Yes.
kind of is just you're compensating, you're changing the way you think about when you get up out the chair, you change the way you're getting up. This one's gonna start bothering you. And there might be some, like we said, some minor things that we need to kind of work on, and well, not necessarily minor, but like muscle imbalance that we need to get
Sure, what happens is like, if you hurt think about somebody who sprains their ankle, and now they're hopping around, all their weight's on their left side, all the demands shifts from right to left. So that becomes the dominant side that's being overused, overworked. And so this gets to recover, and this one takes on the brunt of the workload while the opposite side's recovering. And then you'll see oftentimes too, like, 2 x-rays, right knee looks way worse than the left. There's no pain in the right knee, even though that's the knee that looks bad on the x-ray. Doc's like, we gotta have surgery on that one first. And the patient's like, well, it's my left one that hurts. It's because the right one, most times it's because the right one's worse and they're avoiding it. And so the left is the one that's being overused. That's the one that they notice that hurts because of that.
That's what my x-ray looks like.
Yeah,
Yeah, and so,
and it just makes you feel like, wait a minute.
right, so you just kind of validated that point, right? So
Yeah,
your left side, if I remember correctly, is the bad side, but your right side hurts now?
Yeah.
Right, so over however long it's been, so by trying to alter it or ignore it, the opposite side, well, you haven't ignored it, you've taken steps, but the opposite side's taking on the brunt of that workload, and now it's suffering. So we need to restore normal mechanics to reduce pain,
Yeah,
right? So, okay, do y'all have any other questions or?
we grab Sherry.
So kind of what we would do, so so again, thank y'all for coming out. And the next step is to come in for a one-on-one evaluation or a screen. So Sherry is gonna kind of run through that for you guys and kind of explain it to you. But we can get y'all signed up for that today if y'all would like, if y'all have time. Where basically we offer a free screen, which is basically we just kind of touch base with you, look at you. It's not as in depth as an evaluation, and then it would be able to establish a little bit more one-on-one time with us, and about 10 to 15 minutes. And then at that point, if you're appropriate for PT, we would get you scheduled for initial evaluation. We'd become an active patient.
Why don't doctors communicate more regularly with you guys instead of just jumping to, well, let's just cut that open though, let's go ahead and lengthen that, and it's,
Right.
instead of something like stretching, you'll lengthen that tendon. If it's so tight and pulling on your lower back,
Sure.
they just want to go invasively, let's have surgery.
Yeah.
And I'm finding that it's your hip bone connected to your knee bone connected, but they're all separate now. So
Sure.
everybody deals with it separately.
Sure.
And they don't, you know what I mean?
You come to a PT, you get PT, you go to a surgeon, you get surgery, you go to a chiropractor, you get chiropractic care, and so on and so forth. We have a really good working relationship with a lot of the docs around here. They're not all cut happy. And so it also depends on.
Names of those that are not unhappy.
We have a list. We have a good working relationship.
The first visit, I asked my primary care physician to send me to an orthopedic. And he took a couple x-rays, he walks in, he says, your knees are terrible, you need knee replacements.
Right.
Right off the bat.
Yeah, that could be very overwhelming and like shocking, right? And so, there's some I can't talk for all of them, but some of them, I'm not gonna say they're cut out, but they'll be more quick to go that route. And that's where knowledge is power, and having the information that there's more options than just that. Let's try to exhaust these conservative options, and then ultimately, if this is where I wind up, good. And in the meantime, it wasn't a waste of time because I improved my function along the way. And I put y'all put tools in y'all's tool bag that y'all learned from the exercises, the stretches and whatnot, to where you're prepared for ultimately if you wind up having that surgery. So it's not just a total loss.
Being proactive in your care and taking a non-invasive approach.
Yes,
My
ma'am.
question is, my initial problem was my sciatic nerve.
Right, the old side.
I lifted some heavy weight that I shouldn't have lifted, but I did, and I've dealt with that for several years, like I say, but I had no problem with my knee and my hip. But this is all triggered since that time,
Sure.
and I don't know if it flared up because of taking the shingles or,
Right.
I don't know.
And then the immobility that came along with that. So it's an involved case that would really need to be really looked at and sorted out, diagnosed.
Bone doctor's appointment in Baton Rouge on the 5th,
Mhm.
And I'm hoping, I've been trying to get somebody to do some MRIs, I need to know, is it a problem, is it a bone cancer, is it, what is it? You know, what's the
Sure, and
problem?
that's something that we can help guide you along that path, you know, that's what we do, so we're experts, so nerve, muscle, and bone experts, that's what, we've been through extensive training and education and continuing ed, that's what we do, so, we're shoulder, knee, back, you
All
name
the
it, like,
above.
all of the above specialists, so that's something that we can help guide you through making some of those decisions, and we can help point you in the right directions, so if you're not PT appropriate, I can point you in the direction for where you need to be. And give you those references.
I'm definitely interested in it, but I do wanna go to this.
Sure, absolutely,
doctor
yeah.
first.
Like I said, we work comprehensively with,
Very direct with the doctors.
yeah, we're not like, in our own little bubble, right? The better communication we all have with y'all's providers, with y'all, your family, us, everybody, the better picture that you can paint for your specific situation, and the more accurately we can treat you.
Yeah.
So, yeah, absolutely. Okay, so with all that being said, thank y'all for coming out tonight.
Thank you.
Sherry,
Sherry's gonna take the floor.
Yeah, so, anyone who's interested in scheduling this, just that free exam, that quick exam where we don't have to go through your insurance, raise your hand.
Oh, you don't
Yes?
have to go through insurance.
not for the screen.
So
for the
Claudia is gonna come walk over to each of you and offer a date and time. It's pretty simple. We just need your name, which knee it is, or what's left, right, or both, and then we'll get you to pick a date and time. The other, initial evaluation is more like Matt said, it's a full hour. We'll go through insurance. Now, there are a lot of insurances that do not require a referral. One of the ones that does is Medicare. So if you have Medicare, the best way to go is to schedule that free exam, meet with Matt, let him write something up so that you can bring it to your doc, and then bring a referral order with you, a blank one, they can sign it, and then we'll get you set up for that full-blown evaluation. It's easier that way just because, we can build that rapport. We have those relationships like you said, and that way it just kind of gives the doc a little insight as to, what Matt and you just discussed on that free exam.
So you evaluate like posture and all that?
The whole,
It's very comprehensive, absolutely.
Hmm, okay.
You said you accept 100% of all Medicare pays, or
Yes.
just a portion?
We do. So if you don't have a secondary insurance, the patient's portion is 20%. So say on average, we receive a $100 reimbursement from, we would say 20% of $100 is $20. So you would pay $20 a visit, if you didn't have a secondary insurance. So a lot of people will have a secondary insurance who picks up that Medicare, 20% responsibility.
No, I come from
For
high
sure,
school.
that's right here for
So you
life.
wanna do that?
They pay 100%.
100%? Are you also with the DA?
Yes, sir.
Okay.
So the direct VA does,
I believe so.
so direct VA does require a referral.
Right, right.
And thank you so much for your service.
That's what I really.